Good evening, everybody. My topic being unraveling MRI-based biomarkers of cerebral and retinal vasculature in central retinal and branch retinal vein occlusion, it being a comparative study. So we'll start with retinal venous occlusion, which being the second most common retinal vascular disease after the diabetic retinopathy. Branch retinal vein occlusion is basically a localized block within the branches, while the central retinal vein occlusion affects the central retinal vein, impacting the entire retina. Here we can see the pictures of one being the normal eye, the right eye, the left eye showing the central retinal vein occlusion, and here we can easily demonstrate the right eye being the normal and the left showing branch retinal vein occlusion, the supratemporal quadrant. So here we involve 50 patients with one eye being diagnosed with either of the two, retinal vein occlusion, and the other being the normal eye which we took as the control. After a thorough ophthalmological evaluation, we evolved the three parameters being ophthalmic artery, internal carotid artery, and optic nerve subarachnoid space width 3 and 9 and 15 mm retrobulbar. The purpose was basically the aim of the study to evaluate the MRI-based biomarkers of cerebral and retinal vasculature in retinal vascular occlusion at a tertiary healthcare center. It was a single center retrospective case control study being held at MDI hospital. Here we involved the inclusion criteria being the patient having the other contralateral eye being normal and not to be treated with any sort of antivascular endothelial growth factor, and the exclusion criteria being bilateral retinal vein occlusion and patient with recent intraocular surgery in any of the eyes. So we included the 50 participants. We found that there was no statistical differences based on age, gender or BMI between the participants with BRVO and those with CRVO. The diameter of the ophthalmic artery in the contralateral normal eye of the BRVO patients was significantly narrower as compared to the CRVO group. However, there was no statistical significance in the diameter of the internal carotid artery among the four groups. Here we can see this table. It illustrates that out of the total study of the participants, the mean ICA diameter was not statistically significant. However, here we can see the t-value and the chi-square. It demonstrates that there is statistical difference. The findings showing diabetic patients having higher ICA stenosis, wider optic nerve subarachnoid space width in diabetic patients versus non-diabetics. Here we can see CRVO shows narrower internal carotid artery and wider optic nerve subarachnoid space width, and arteriovenous ratio significantly worse in the CRVO group. Here the graph illustrates the higher IOP association with the wider optic nerve subarachnoid space width. So the optic nerve subarachnoid space width in a CRVO affected eyes are significantly wider at 3 mm and 9 mm behind the globe as compared to the contralateral normal eyes. Additionally, the optic nerve subarachnoid space width at 3 and 9 mm behind the globe in CRVO affected eyes was significantly wider than in the BRVO affected eyes. Further, optic nerve subarachnoid space width at 3 mm behind the globe in CRVO contralateral normal eyes was significantly wider than the BRVO control group. The arteriovenous ratio was significantly statistical difference between the affected and the contralateral normal eyes in CRVO group. The retinal venular caliber and the AVR ratio in BRVO affected eyes was significantly different in CRVO group. So this is a chart showing the difference that we found in the study. As we can see with the MESA trial, which was a prospective cohort study, there was arteriovenous caliber can be predict the risk factor for the stroke. These changes in the lumen diameter are sensitive indicators of endothelial dysfunction, which is influenced by factors such as inflammation or the blood flow differences. A meta-analysis also found that the RVO had 50% higher risk of cerebral vascular diseases and 16.8% increased risk of stroke according to the population-based study. The limitation of our study being it being a case control study which prevents a causal relationship to be established. Further studies should involve a larger sample size and a well-designed cohort study. Optic nerve subarachnoid space width and invasive method is indirectly assesses CSF pressure could be replaced by more convenient technique like B ultrasound, which accurately evaluates CSF pressure by calculating the area of the orbital optic nerve subarachnoid space width. Hence, I would like to conclude that the study found that the ophthalmic artery diameter and AVR ratio was significantly narrower in BRVO as compared to the CRVO. So this can be the risk of the cerebrovascular disease higher in the BRVO patients. Therefore, patients with BRVO should be considered for MRI, brain, and angiography. So these are the references.
So the pathogenesis, as we know, is different for BRVO and CRVO.
Yeah.
So what is the practical implication of this study?
So practical implication being, if we conduct more of the cohort studies, we can go more patients of BRVO being evaluated for MRI so that we can decrease the risk of cerebrovascular accidents in patients. We can predict and we can take appropriate treatment for that, sir.